Hi, my name is Paige Semble and this is my NRSG265 project on multiple sclerosis. The purpose of this presentation is to educate my audience on the pathophysiology, epidemiology, pharmacology and nursing care for multiple sclerosis. My chosen scenario is a 32-year-old Irish female named Danielle Costa, who presented to the emergency with a new onset of blurred vision in her right eye, unsteady gait over the past 48 hours. She reported increased fatigue, mild urinary urgency, and tingling in her left hand. She reports a family history of multiple sclerosis via her father, and further neurological investigations confirmed a new diagnosis of multiple sclerosis. Multiple sclerosis, also known as MS, is an inflammatory demyelinating condition that is caused by an autoimmune attack of the myelin, which is the fatty substance that surrounds the nerves of the brain and spinal cord. This then disrupts the electrical impulse that is meant to be sent through the nerves to the rest of the body, and instead results in scars, otherwise known as plaques or sclerosis. There was a prevalence of 33,335 Australians living with MS in 2021, which is a significant increase from past years. The prevalence of MS within Australia is actually higher in the southern states compared to that in the northern regions, with Tasmania having the highest increase in prevalence from the years 2017 to 2021, which can be seen via the graph. The latest data shows that in 2021, the incidence rate was approximately 3.5 cases per 100,000 people between the years 2011 and 2021. Some at-risk populations include white Caucasians and young females, with the median age being 31 years old and 64% of patients being female. Some risk factors for MS include genetics, such as family history of the disease, environmental factors such as low exposure to vitamin D and smoking, age and gender, with those being female aged 20 to 40 being the most at risk, as well as geographical location, such as being further away from the equator. Due to the rising prevalence of MS within Australia, this has implications for the quantity of resources needed to treat and manage this disease, today and in the future. This includes the cost and availability for treatments, disease-modifying therapies, medical specialists, and research to help prevent MS in the future. The estimated cost of MS to the Australian community in 2021 was $2.5 billion, which shows the substantial burden this disease is placing on our healthcare system. The pathophysiology of multiple sclerosis is quite complex. The underlying mechanism of this disease is an autoimmune attack of the myelin of the nerves. To explain this further, the immune system mistakenly attacks the myelin sheath, which is the fatty insulation layer around the nerve fibers of the central nervous system, which then leads to increased inflammation. The T cells, which are normally responsible for killing infected or cancerous cells, cross the blood-brain barrier and release cytokines, which recruit other immune cells to aid in the attacking process, which then causes increased inflammation of the brain and spinal cord. This then leads to a process called demyelination, which is when the myelin is stripped off the axons, thus impairing the saltatory conduction, which is the rapid jumping of the action potentials across the nodes of Ranova. Over time, this repeated action will cause a buildup of inflammation and scarring called sclerosis, and then leads to irreversible axonal loss and neurodegeneration. A fundamental characteristic of MS is the presence of demyelinated plaques scattered throughout the CNS, including the optic nerves, brainstem, and spinal cord. This pathophysiology has a strong link to the clinical symptoms people with MS present with. For example, the conduction block from the demyelination causes failed or weakened transmission of the nerve impulses, which leads to motor weakness, spasticity, and fatigue. There is also such thing called remyelination, and this is where the body can naturally repair the myelin of the affected nerves. This explains why some people can have flares in their symptoms and then improve. Remyelination is a goal of many developing treatments and trying to aim towards. This highlights the importance of addressing both the underlying disease mechanisms and the resulting symptoms of MS. The core issue is immune-mediated myelin destruction, so the main treatment focuses on disease-modifying therapies. Examples include interferon beta, which reduces the relapse rate and new lesions, and monoclonal antibodies such as natalizumab, which targets specific molecules to block growth or trigger immune responses. Rehabilitation strategies like physiotherapy and occupational therapy help to maximize the remaining function and preserve the quality of life. Patient education is also vital in enabling individuals to understand their condition and manage triggers such as stress, infection, and heat throughout their lifestyle modifications. As I mentioned previously, a common medication that is prescribed for patients with multiple sclerosis is natalizumab, also known as Tysabri. This is currently available on the PBS for Australian patients. This medication is an immunosuppressant and falls under the humanized monoclonal antibodies, or the IG4, and it is the first drug developed in the drug class of selective adhesion molecule inhibitors. The mechanism of action for this medication is as follows. It binds to the A4 integrin protein receptors on the leukocytes, which prevents their interaction with the vascular cell adhesion molecule. that are present on the endothelial cells. This therefore inhibits the lymphocyte adhesion and blocks the migration across the blood-brain barrier, thus reducing central nervous system inflammation, demyelination, and axonal damage in MS. The indication for this medication is relapsing remitting multiple sclerosis, which includes clinically isolated syndrome and active secondary progressive disease. It is a high-risk medication and not yet confirmed safe for people under the age of 18. Some nursing considerations for this medication include pre-treatment checks, such as assessing the patient for any immunosuppressant history, obtaining informed consent after speaking about the risks, as well as obtaining a baseline MRI and anti-JC virus antibody status to stratify the risk of PML. This medication is to be administered via an IV infusion every 4 weeks, and the patient needs to be monitored for at least 1 hour post-infusion to ensure there is no hypersensitivity or infusion reactions. Due to this medication being high risk, there is also a need for ongoing monitoring throughout the time the patient is on the medication. This includes repeat anti-JC virus antibody testing every 6 months as per the natalizumab protocol. Regular MRI scans are done to promote early detection of PML, as well as being on the general lookout for any adverse effects such as infection, fatigue, and infusion reactions. Some other adverse effects that may be relevant to Daniela is liver damage, weakened immune system, UTI, as well as general fatigue and headache. An acute issue that Daniela is facing is neurological deterioration that is related to demyelinating relapse caused by an acute MS exacerbation. This is evidenced by a sudden onset of new neurological symptoms, such as unilateral blurred vision, limb weakness, ataxia, and tingling in her left hand, with symptoms lasting longer than 24 hours and severely disrupting Daniela's daily function. My nursing goal would be to stabilize Daniela's neurological function and reduce the severity and duration of the relapse to assist in promoting recovery and prevent long-term damage. 3 evidence-based nursing interventions I would conduct would be the administration of high dose of IV corticosteroids. I would justify this as corticosteroids reduce central nervous system inflammation and speed up the recovery from relapse by weakening immune response and limiting further demyelination. My second intervention would be highly frequent neurological assessments and monitoring. I would justify this as constant monitoring and assessment can detect progression and complications early on. It also helps provide a baseline for further assessments and can help to assess the effectiveness of treatment Daniela may be receiving, such as the corticosteroids. My third intervention would be monitoring Daniela's vital signs, fluid balance, and glucose levels during her steroid therapy. I would justify this as corticosteroids can cause hypertension, fluid retention, changes in mood, and hypoglycemia. Therefore, constant monitoring will help detect if any of these adverse effects are prevalent and can help reduce the risk of further complications. Thank you for listening, and here are my references.